let's get started. Moving on to lecture 6. We're going to be talking about the indirect antiglobulin test, or the IAT. So if you guys have ever watched any of the medical shows, you might hear, let's get a type-in screen, ordered stat on this patient. This is your screen. This is your indirect antiglobulin test, the IAT. So every patient in blood bank that comes through will get an ABO, RH, NA, IAT, or antibody screen. Okay, this is, we're screening for any unexpected antibodies, so not the ABO antibodies, but other antibodies to other red cell antigens. Okay, so this uses patient plasma. Okay, still uses your AHG reagent, your anti-human globulin reagent, but we're testing patient plasma. Patient plasma is where our what? Antigen or antibody is. Antibody is in your patient plasma. We're going to mix patient plasma with our commercial reagent cells, which is where our antigen is. Okay. If you have a reaction in your IAT, that means your patient has an antibody to something that is on your screening cells. Okay, and so then we need to identify what antibody is present. Okay. All right, so the purpose of the IAT, again, that's your antibody screen. It's a 2-stage, some might even describe it as a 3-stage procedure. And again, we are detecting in vitro sensitization of red cells. We are making this antigen antibody complex occur. Okay, we're mixing patient plasma where the antibody is with commercial red cells where our antigen is. Okay. So most oftentimes when you do your IAT, you'll have 3 steps. You'll have your initial span test, and then you're going to incubate at 37 degrees, probably for about 15 to 30 minutes, okay, depending on if you've added any enhancement media. Or, and then you will read for agglutination after 37 degrees. Then you're going to wash. You're going to wash 4 times, and then you're going to add AHG. Spin and read for agglutination, both macroscopically and microscopically. Okay, remember, anytime you add AHG, you have to check it under the microscope as well. Okay. And again, make sure you understand patient antibodies are in the plasma, and then your antigens are on your commercial manufactured red cells. So we know the antigenic profile of those cells. So we can match the pattern of reactivity in our patient plasma with the presence of the antigen on our commercial cells. And we're actually going to do that today. So keep in mind, this is identifying any unexpected IgG antibodies. Okay. All right, so there's several things that we want to think about when we're encouraging this antigen antibody complex, things that affect sensitization. One of them is the antigen antibody ratio. Okay, remember, we always want the zone of equivalence. Okay, and so you are dealing with, when you add patient plasma, you're dealing with patient antibodies. So typically when you're dealing with patient plasma, you'll want a little bit more plasma, a little bit more antibody than antigen. Okay, so usually for your IAT and your panel, you'll add 2 drops of patient plasma to 1 drop of cells. Okay, that gives us that zone of equivalence. Little more opportunity for the antibody to bind to the antigen on the commercial red cells. pH, ionic strength, the temperature, and time all play a role as well. Right, so we're going to talk about how the blood bank varies these. So antigen antibody ratio, like I mentioned, that antibody is more likely to bind when the antibody is present at just a little bit higher ratio. And the reason for that is oftentimes these patient antibodies are, what if they're low titer? Okay, so we want to make sure we have enough antibody that we can visualize the antigen antibody complex occurring. Okay, so we always add a little bit more patient plasma, and you even see that in your ABO testing, right? When you do your back type, you add 2 drops of patient plasma, and that's just because we want to make sure we have enough patient antibody to allow for this reaction. And if you want to take it to the science, you have your serum still ratio, serum to cell ratio. So you'll have 2 drops of serum, 1 drop of cells. Okay, that just really increases the chance of the antigen and antibody coinciding, making that connection for the lattice formation, the agglutination. All right, pH. You want your pH, the desired pH in blood bank, we want it to be between 6.5 and 7.5. The isoelectric point, meaning that the point in which your cells take on a neutral charge, is 7.5, okay? So if you have an extreme lower pH or an extreme higher pH, then it's less likely that the antibody will be able to bind to the red cells. All right. So here's an example. Notice that if your pH is at 7, you have the negative, so you have your zeta potential that surrounds your cells, that negative charge that surrounds your cells, and then you're at a pH of 7, the antibody takes on that positive charge, the opposites attract, and so you'll better be able to see the antigen-antibody complex forming, okay? Versus if you have an extreme, and I wish this pH was a little bit more extreme. I think at 7.5 it would still occur, but I wish this number was either way lower or way higher to be an extreme. But notice the antibody is still way up here, all right? So it can't overcome that zeta potential. Okay. Right, then your ionic strength. Think about the zeta potential, the negative charge that's surrounding these cells. It is thought that the amount of negative cloud around the cells is directly proportional to the zeta potential. So the larger the cell, the negative charge around the cells, the higher the zeta potential, the more we have to get that antigen, we have to work for that antibody to come to the antigens on the cell, okay? So how can we do this? How can we decrease that zeta potential? There's a solution in blood bank that is often used with the IAT and your antibody identification, and it's called LISS, or low ionic strength solution. And what it does is it just helps to decrease that zeta potential, allowing the antibody to uptake onto the cells, right? Therefore, we have the antigen-antibody complex forming, and then we are able to visualize that. You guys in the academic 9B lab, you guys will use LISS. Do not be surprised if once you enter the blood bank clinical labs, they do not use any enhancement media, whether it be LISS. There's another one we're going to talk about, PEG. Some people might even still use albumin. I doubt you'll ever see them using albumin. It's really kind of been obsolete. Hardly anybody ever uses albumin. Why? Albumin is a protein. Excess protein can cause false positives. Okay, so while protein might have been used as an enhancement media a long time ago, it's not really very common now. And because our blood bank reagents have improved in manufacturing process as well. And then, so here's just an example of the zeta potential. Notice that IgM molecules are so large, they don't have any problems bringing the cells together. The multiple binding sites of the IgM molecule, the size of the IgM molecule, it's easily able to overcome that zeta potential. Poor little IgG has such a hard time. He's so small, okay? He wants to get there, but he has more challenges, all right? So we have to help him. We have to help him make it to the cell, all right? That's why we use this. That's why we use PEG. That's why we extend our incubation times. That's why we incubate at 37 degrees. As we start talking about our specific antibodies, some of them will only react at 37 in AHG phase of testing, okay? All right, temperature. Temperature acts by enhancing that reaction. It further allows the antibody to come to the cell membrane, allowing that antigen-antibody complex. All right, very important. You guys probably already know this, but for blood bank, this will play a very important role when you're identifying your antibodies. Given that we have 3 phases of reaction, you have your initial spin, you have your 37, you have your AHG. If you're dealing with an IgM antibody, think about our ABO antibodies. They're all IgM. You guys have seen they all react at room temperature, right? All you have to do is add your red cells and your plasma, spin it, read for agglutination. It's there, right? Those are all IgM. For IgG antibodies, they are very small and they like to react. We're mimicking what's going on inside the patient's body, all right? So oftentimes your IgG antibodies will not react until at least that 37-degree incubation phase, okay? They have to have that temperature increase. Okay? We call this for those antibodies that react at 37, think about that's what temperature your patient is, right? That's your body temperature. That means we are mimicking what's happening inside your body, okay? So any antibody that reacts at 37 degrees or AHG phase of testing, we will call it clinically significant. It must be honored, whether that means giving antigen negative blood, okay, meaning that if your patient has an antibody in their circulation reacting at 37 degrees, we don't want it to attack your donor cells, all right? So if you're dealing with an antibody, and as we start doing antibody identification, I'm going to ask you a series of questions. Is this clinically significant? All right, clinically significant means, number one, it's reacting at 37 degrees. It can cause a transfusion reaction. It can cause hemolytic disease of the newborn, meaning that it can cross the placenta. Okay? However, IgM typically only reacts at room temperature or colder. IgM antibodies will react at 4 degrees as well. Okay. And if you think of room temperature, it's usually about 22 to 24 degrees. And blood bank will always, as you guys start entering blood bank, we will always be monitoring our room temperature. So that's part of our daily QC. We want our temperature to be probably 22 degrees plus or minus 2 degrees. Right, so that's why temperature is so important in blood bank. Also time. We want to allow enough time for that antibody to bind to the antigen on the cells. So that's why oftentimes it's very important, especially if you're using commercial antisera, you read your manufacturer's package insert. As we start going into phenotyping and certain things like that, they will all have different incubation times, okay? Typically, in blood bank, your incubation time is going to be 15 minutes, okay? That's usually a good incubation time. If you're dealing with an antibody, you're trying to get it to react, oftentimes we will extend that incubation time to 30 minutes. And that's usually a standard step that we take in blood bank. However, as you guys start doing your IATs, you don't want to cause such a delay in your testing. If you incubate, and I actually had this happen to me in blood bank, and I was notorious for incubating my tubes, setting my timer, walking away, and then I kind of became obsolete to my timer. Like I just wouldn't hear it go off. And then I would be like, oh, let me go check my results so I can enter in the computer. My IAT or antibody screen or panel had been incubating for an hour, okay? That's too long. So if you have prolonged incubation times, it can dissociate the antigen-antibody complex, okay? So then I had to repeat my test and re-incubate, right? So you want to allow the appropriate incubation time, but you don't want to go too long. And that's another reason, if you guys remember in lab last week, I talked about time management, right? That's another reason that you always want to have that timer set and pay attention to it. Blood bank is so loud. I don't know if you realize how loud blood bank is going to be. If you're going to have refrigerators, you're going to have freezers, you're going to have centrifuges. If you're automated, you're going to have instruments going, you're going to have timers going off nonstop, centrifuges. It's very loud. And so sometimes I don't know what the right word is. The timer would go off and I wouldn't even hear it. I was just like in my own little world, I guess. So yeah. Usually my coworkers will be like, your timer's going off. All right, so there are some agglutination enhancers. Centrifugation is one. So in blood bank, we will always centrifuge at 3,400 RPMs. If you're doing initial spin, it's usually about 15 seconds is the desired. You can extend that to 30. As you get into some special phenotyping, they might have specific centrifugation times. Sometimes it might even go for 45 seconds to 60 seconds, right? But for most part, it'll always be 15 seconds. And again, the purpose of centrifugation, the centrifugal force pushes those cells together, allowing for the antigen-antibody complex to occur. And again, if you're dealing with an IgM, you'll typically have agglutination after initial spin centrifugation. Again, IgG, we usually have to encourage it. All right, so how can we encourage it? We talked about LISS, right? LISS will lower the ionic strength, all right? So reduce that zeta potential, allowing for antibody to uptake on the cell. There's also albumin. Albumin has a negative charge at the desired pH, so it will dissipate in the saline solution. It takes shorter amount of incubation time, but albumin is known to have false positives, right? So albumin is not typically used anymore. And then there's PEG. He is polyethylene glycol. What he is going to do is he is going to remove all of the excess water in the test tube atmosphere, further allowing for antibody uptake onto the cells. Okay. Some labs will still use PEG. However, if you're dealing with a warm auto-antibody, PEG is known to enhance warm autos. Okay. It has been my experience when I was working in blood bank, we did not use any of these enhancers. And if you ask me why that is, I would say that the manufacturing process of blood bank reagents has improved drastically over time, and so these typically aren't needed anymore. As we start getting further into antibody identification, there's another process that we will talk about. It's your proteolytic enzymes. This is usually papain or physin. It's not really an enhancement media. It's not really a potentiator. What it does is it's used as further investigation and antibody identification. And the reason for that is while it might enhance your RHs and KELs, it destroys the antigen site on MNS and Duffy. It destroys those. So if your patient has an antibody to MNS or Duffy, those reactions after enzyme treatment are going to go away. So if you are trying to identify multiple allo antibodies, enzyme treatment is a really good way to get rid of some reactions. Let's say a really good example to use enzyme treatment is if you have a Duffy A or a Duffy B antibody, and you have maybe only like 2 negative reactions on your panel, then you could get rid of the Duffy A antigen on your commercial cells and then see if the patient has any other reacting antibodies. Okay, so how does the IAT work? You're going to take your patient plasma, okay? You're going to mix it with their group O cells with known antigenic profiles, okay? We know what antigens are on those cells. At this point, you could add any potentiators. You would add LISS. You guys are going to use LISS in the 9B lab. Then you're going to incubate. And read after 37. So you read at initial span, then you're going to incubate at 37, you're going to read after 37, and then you're going to wash your tubes. So wash your tubes 4 times, and you're going to add your AHG reagent. Okay, wash your AHG reagent, immediately centrifuge, and read for agglutination. Okay, that's your 3 phases: initial span, 37, and AHG. So here's what's going on in the IAT. I want you guys to understand the difference between DAT and IAT. Remember in the DAT, we were using patient cells mixed with our anti-human globulin. In the IAT, we're using patient plasma mixed with commercial cells. So you always have to ask yourself where the antigen is coming from, where the antibody is coming from. Okay, so in the DAT, we're looking for antibody-coated cells. In the IAT, we're looking for any unexpected antibodies in patient plasma, right? So we have our patient plasma, okay? This is where our antibodies are, mixed with commercial manufactured red cells, okay, with known antigenic profile. If your patient has an antibody to one of the red cells, or one of the antigens present on the red cells, sensitization will occur, okay? Then we're going to wash any unbound antibody, and then we're going to add AHG. All right, so then that IgG, we're using monospecific IgG here. All right, typically in your IAT, you use monospecific IgG. It will bind, it's going to bring the cells together, allowing for visualization of agglutination. Okay. Does everybody understand the difference between IAT and DAT? Yes?
So DAT would be like in vivo, where IAT would be like
Exactly. So DAT, we're detecting the antibody that has attached to the red cells in vivo. okay? This is plasma. We're adding the antigen. We are making that antigen-antibody complex occur. Okay, this is in vitro. So what are the uses of the IAT? I mentioned antibody screening. Every patient, before they can be transfused, must have an IAT, okay? And the reason for that is that IAT detects any unexpected allo IgG antibodies. And then also any auto-antibodies as well. And remember, the importance of this is because any IgG antibodies that is present in patient plasma is unexpected. All right, we know their ABO antibodies are there. That's normal. This is not normal to have an unexpected IgG allo antibody, okay? And remember, the only way you can get those is for females who have had a previous pregnancy or transfusion, right? Phenotyping. We will use the IAT in phenotyping, and what I mean by phenotyping is we are determining the specific antigenic expression of your patient cells and or your donor cells, okay? So this is where in vitro versus in vivo becomes very important, because while you're using cells here, you're still using anti-human globulin, but you're adding the antibody, okay, to see if it will combine with your patient or donor cells. All right, that's phenotyping. We're not there yet. You guys don't have to worry too much about this. We will talk extensively about phenotyping after we get through the antibody identification process. Just remember, another thing with phenotyping is if you find out your patient is antigen negative, remember, always remember Landsteiner's rule. If your patient is antigen negative, then they can build the antibody for it, okay? So if you find out your patient is DEFI-A negative and they have an antibody reacting in their plasma, we want to make sure that it's not DEFI-A, all right? That's one of the potential antibodies that it could be because he's DEFI-A negative. This is very important for sickle cell patients. We see a lot of sickle cell patients in blood bank because one of the most known treatments for these guys is transfusions, red cell exchanges. And we want to remove all of that abnormal hemoglobin S and give them normal hemoglobin A, all right? So they will have multiple transfusions over their lifetime. They will build multiple antibodies. Oftentimes, sickle cell patients are a very complex workup. And there's a new regimen that was rolled out maybe about 7 years ago for sickle cell patients. We try to establish a baseline phenotype on them, and that way we can give them phenotypically matched units. So we will give them donor units that have the same antigen profile as they do, therefore they will build less antibodies, especially for your RHs and KELs. All right, and as we start talking about some of the others, depending on like your DEFI-A and DEFI-Bs, most commonly found African American populations being negative, so they will tend to build those antibodies very quickly as well. So that's something else we always pay attention to in sickle cell patients. Right, so that's phenotyping. Another way to look at phenotyping is your antigenic expression of the cells you're testing, whether it be your recipient or your donor. Crossmatch, we will also use the crossmatch. And what the crossmatch is, we talk a lot about compatibility in blood bank. If a patient needs a transfusion, we want to make sure that it's compatible with them. And if they have an antibody, then we will phenotype your donor units to make sure that they're antigen negative for the antibody that your patient has. All right. And one way that we will do that is we will carry that crossmatch through all three phases. So your initial spin, your 37, and your AHG. Okay, so if your patient has a clinically significant antibody reacting at 37 degrees, we want to make sure that we cross-match a potential donor unit to them at that phase 2. So cross-match is you're taking patient plasma, right, and you're mixing it with your donor cells. You're seeing in vitro how your patient is going to react to those cells in their circulation, all right? And so if it's negative, that means that that donor unit, theoretically, if it's antigen negative, okay, is safe for your recipient. Okay. So a negative cross-match means that it's compatible. If you have a positive cross-match, that means that your unit is incompatible. And remember I said that we do the cross-match that we'll do if you identify an antibody in your patient, then you have to do what we call an AHG cross-match. You have to go through all 3 phases. Your initial spin. The reason for your initial spin cross-match, you're taking patient plasma mixed with donor red cells. That is an ABO check, right? Remember your ABO antibodies react at room temperature after initial spin. So if there's any ABO incompatibility, maybe that donor unit's labeled wrong, or maybe you grab the wrong unit off the shelf, you will have a 4+ reaction at initial spin if you have the wrong ABO, okay? So your initial spin cross-match serves as a further ABO check. And we will talk extensively more about cross-matching and compatibility. So you guys don't have to know that whole process right now, just that it does involve the IAT procedure as well. And again, it does use anti-human globulin. Remember, AHG is used both in the DAT and the IAT. And again, it's just bridging the gap. It's encouraging the visualization of agglutination with those IgG because of its size. All right, your IAT will detect your IgG allo antibodies. If you have a positive IAT and the reactions are at 37 in AHG, that is considered a clinically significant antibody. We have to identify it. We have to investigate it. Okay. And again, because it can cause transfusion reactions, it can cross the placenta, right? That's why it's clinically significant. So typically our IgM antibodies are cold reacting antibodies. They react at room temperature and 4 degrees. However, during our 37 phase of incubation, they will dissipate. So usually you'll see them at initial spin, and then after 37, your reactions will go away. That's how you know you're dealing with an IgM antibody. IgM antibodies, because of their size, cannot cross the placenta, and typically they do not cause any transfusion reactions. Why? Because if we're dealing with an antibody that's reacting at initial spin or room temperature, it's more than likely not reacting at the patient's body temperature, right? So it's usually probably not causing that patient any problems. So we typically do not think of IgM antibodies as being clinically significant. Okay. A lot of times blood bankers will view room temperature reacting antibodies other than our ABOs as nuisances. Okay, they're really considered just more of interference in our testing. Now, there are exceptions to that. Anti-M is one. Anti-M can be of IgG classification, where he can react at initial spin, interfere with our back typing, then he'll also react at 37 in AHG. If that occurs, he is considered clinically significant. All right. And like I mentioned, some people consider these room temperature cold reacting antibodies more of a nuisances. Some people will claim that they need to be worked up, need to be identified. Some people will say it doesn't matter because your patient's body temperature is at 37 degrees. It'll have no effect on them. Lewis A and Lewis B is a classification. We have a group of antibodies that are inherited as a haplotype. They are considered non-clinically significant because they react. Your textbook's going to tell you that they'll react at initial spin in 37. I have personally seen Lewis's act very funny, so they don't follow the textbook. So oftentimes for your Lewis A and the Lewis B family, they will react at AHG. However, we will not give phenotypically matched units for them. We will only give cross-match compatible units for them because they're typically of IgM classification, so they're not considered clinically significant. So you kind of have to take that one depending on how it's reacting. But typically, I mean, when we talk about the Lewis family in an upcoming lecture, you have to be Lewis A negative and Lewis B negative in order to build either one of those antibodies, Lewis A or Lewis B. And so what happens is the antigenic expression in pregnant females decreases during pregnancy. So oftentimes you'll see several pregnant females that have either anti-Lewis A or Lewis B. And one of the things is that considered clinically significant in a pregnant female? Well, the Lewis's are of IgM classification. They can't cross the placenta, so they're not considered clinically significant. even though they might be reacting at 37 degrees. So there's some controversy there, all right? So you kind of always have to pay attention to your phase of reaction. All right, so when should you do an IAT? And I mentioned this, every patient that comes through blood bank who has the potential to be transfused must have an IAT, okay? And then when we start talking about donors must have an IAT as well, all right? And then moms and babies. So we will always do an IAT on mom, all right? We want to know if she has an antibody. If she does have an antibody and her baby is antigen positive for her antibody, then that could cause hemolytic disease of the newborn. Okay. So here's your reagents. You're going to use LISS again to reduce the ionic, strength of the solution in your test environment to further allow uptake of the antibody onto the cells. Your incubation time is usually going to be about 15 minutes. You could use albumin, you could also use PEG here as well, but most commonly you're going to probably use LISS. Oops, I think that's a duplicate slide. Oh, maybe not. So LISS increases the rate of antibody uptake, all right, like I mentioned. Albumin further breaks down that zeta potential, okay, allowing the cells to come closer together. However, remember albumin is associated with false positives. All right, and like I mentioned, we're using monospecific IgG. We're not using polyspecific in our IAT because complement, if it has been involved, is on the red cells, not in your patient plasma. So it's not a concern for the IAT. And then you'll have your commercially manufactured screening cells 1 and 2. Don't be surprised if you, some labs will even incorporate a 3-cell screen. So you might have screening cell 1, 2, and 3. Okay, so you either have a 2-cell screen or a 3-cell screen. You have to understand that these screening cells are of group O. Okay, and the reason for that is we're using patient plasma, right? Group O patients don't have any antigens on their cells, correct? Any ABO antigens. So our patient ABO antibodies will not cause reactions in our IAT. So we're able to identify any other allo IgG antibodies. Does that make sense? That's why they're group O. Okay, because you don't want, if you were to use group A cells and you had a B patient who has anti-A in their plasma, all of these cells are going to react at initial spin because the patient's anti-A. And we won't be able to identify any other allo antibodies, right? So that's why they're group O. It's very important that you guys understand the purpose of the IAT. If you think about transfusion patients with donor red cells, if they have a circulating antibody in their plasma, that circulating antibody is going to attack those donor cells. It's going to cause a transfusion reaction. Depending on the severity of that antibody, it could result in, probably going to result in an extravascular hemolysis, but it could result in intravascular hemolysis, especially if it's anti-D, all right? So this is what your screening cells look like. These are commercially manufactured. So each lot number has or each screening cell has a lot number. All right, so when you are testing, you want to check the expiration date of your screening cells because these are red cells. All right, they are usually only good for about 2 weeks. So in blood bank, every 2 weeks, you're going to be doing QC on a new lot number of reagent cells. All right. The thing you have to pay attention to about expiration dates is if these cells start lysing, they could lose their antigenic expression. And when you do your testing, it could result in false negatives. Okay, so you always want to make sure, and then number 1, according to CAP accreditation, you're not able to use any expired reagents, right? So you always want to make sure that they're in date and that QC has been done on them. And QC is done daily, right, on all of your reagents. Unless you're phenotyping and using special antisera, then it's only done as you use. So another thing you have to check, these cells, the manufacturer is going to provide what we call an antigenic profile. And FDA mandates that the manufacturers of these cells include the antigenic profile of all of the clinically significant, most common antibodies. Okay, so that's D, big C, little c, big E, little e, cal, chelano, WA, WB, JKA, JKB, NNS, big S and little s. All right, so all of those must be included. That's your antigenic profile. And it looks like this. So this is a 2-cell screen, right? So they have screening cell 1. The plus signs indicate that the antigen is present on this cell, okay? The 0 indicates that that cell is antigen negative. So screening cell number 1 is D positive, big C negative, big E negative, little c positive, little e positive. Okay, does everybody understand that? All right, so that's your antigenic expression. You guys will always have these whenever you're running an IAT or you're doing a panel for antibody identification. Keep in mind, this is just a screen, right? This just lets you know if there are any clinically significant, most common antibodies reacting in your patient plasma. If you don't have any reactions here, this is all negative, you report that out as IAT negative, your patient is considered good to go for an initial spin, random donor crossmatch. So you don't have to do any further testing. If it's positive, we have to run more cells for definitive antibody identification. Okay. So you're going to write your patient reactions over here. Notice our 3 phases are included. We have initial spin, we have 37, and we have AHG. Right. So you have your 2 cells, and then don't be surprised. You guys in the 9B lab will always do an auto control in your IAT. Most clinical blood banks will not do the auto control in the IAT. If you have a positive IAT, then you do your panel, that's when they'll run the auto control. But for all of our purposes, we'll do the auto control included in our IAT. I don't think that's common practice, but it's what we'll do. All right, so your reactions. So this is patient plasma, okay? So you can write your reactions here. And we're going to do some examples. We're going to do some scenarios. So how can you use these antigenic profiles? All right, so if you had a reaction in your patient plasma with screening cell 1, but not 2, that means there is an antigen present on screening cell 1 that is not present on screening cell 2. So you're going to look at the antigenic expression of each of these cells, and you're going to see what's on screening cell 1, but not on screening cell 2. Notice that D is on screening cell 1 and 2. So if the patient had anti-D, we would expect a reaction with both screening cells 1 and 2. Does that make sense to everybody? All right, so in our scenario, we only have a reaction on screening cell 1. So could little c be an option? All right, little c is present on screening cell 1, but not on screening cell 2. That could cause the reaction in our patient plasma. Okay, what about M? Do you think M is an option? No, because he's present on screening cell 2, not screening cell 1. Okay. What about N? Definitely N is an option. What about big S? Typically not, because he's present on screening cell 1 and 2. So we would expect if he was reacting, both cells would be positive. Lewis A is an option. Big K, Kel is an option. And then JKB would be an option, right? Those are positive on screening cell 1, but not on screening cell 2. Does everybody kind of see how you can use the screen? Okay. So if you have a reaction that occurs in either screening cell 1 or 2 or both, that means your patient has an allo-antibody, which is reacting with the antigen that is present on your screening cells. So here's an example. Notice this one. This is an actual anagram from an ortho manufacturer. It's a 3-cell screen, so you have 3 cells. Okay, notice our reactions over here in patient plasma. 3+ reaction at initial spin, 37 in AHG. All 3 cells are reacting, and our auto control is reacting. What do you guys think about that? Yep. So this patient has a auto-antibody. Do you think it's a warm reacting antibody or a cold reacting antibody?
Because it's reacting.
It is reacting at room temperature and 37, definitely at AHG. So this is probably actually a warm auto-antibody. So do you see how with all of these reactions, you can't really rule anything out, you can't really rule anything in. This is the complication with patients that have an auto-antibody. Everything is positive. Given that you have a positive auto-control, what's your next step? DAT, very good. You would have to do a DAT on this patient. Given that his auto-control is positive, there is something coating his red cells. We need to do a DAT to find out if it's IgG and or complement. Okay. So that example lets you know what a warm auto-antibody would look like. Take a look at this example, and this is actually what I printed out for you guys, so you can see if you can identify the potential antibodies. Notice that we have negative reactions with all three cells on initial spin. We have a 2+ reaction on screening cell 1 and 2 at 37 degrees and a 2+ reaction at AHG. What do you think these two reactions right here are? The column is labeled CC. Check cells, all right? So notice screening cell 1 in your auto control were negative at AHG. So we added the anti-human globulin phase. It was negative macroscopically and microscopically, and then we added check cells, okay? So after you add check cells, you still have to grade for agglutination, okay? Do not, remember I said, do not think these reactions right here reflect what your patient is reacting. Okay, we made that positive reaction. Okay, so don't think screening cell 3 in your auto control are positive.
That's just confirming the validity of the negative reaction.
Yes. Check cells confirms your addition of anti-human globulin. What if you didn't add your reagent? You could have a false negative result, and then if you added check cells, you wouldn't have any agglutination. Okay, so number 1, check cells confirm your negative result, the addition of AHG, and number 2, that the AHG was working, that you adequately washed all the cells, removed all the excess protein that could neutralize that reagent and prevent it from binding. Okay, so we have reactions on screening cell 1 and screening cell 2. Do you think this antibody is clinically significant?
Yes.
Yes. Do you think it's of IgG classification or IgM? IgG. And based on that it's present on screening cell 1 and 2, but not on screening cell 3, what antibody do you think it is? Could it be D? Yes. Could it be big C? Could it be a combination of big C and big E? Oh, it could be. Because big C is present on screening cell 1, big E is present on screening cell 2. Could be a combination of those two antibodies. All right, so you got to keep that in mind too. These patients can have multiple antibodies. Okay. Could it be little c? Probably not, because you have negative reaction on screening cell 3, right? So if little c was there, you probably have a reaction with this cell. Do you think it's little e? No. F is a compound antigen, very rare. CW is very rare as well as the kel. Do you think this could be kel? No, not likely because of that negative reaction on screening cell 3. What about Chelano? Chelano is it's in the kel family. It's a high frequency antigen. Notice that it's on all 3 screening cells. 99% of the population are positive for the Chelano antigen. All right, so it's very rare to find a Chelano antibody because everybody's Chelano positive. Right, so they're not going to build it. KPA and KPD are also in the kel family. Again, they're a little bit more rare. JSA, JSC. What about VEPA? No, because he is negative on screening cell 3, all right? So negative here has a positive antigen here, so that lets us know the patient's plasma is not reacting with that cell, right? So it's probably not WA. Again, this is not a definitive answer, right? You have to run more cells for confirmation. You have to do your rule out procedure, which we'll get to in the next module. Anything else that could potentially be? Could be little s, right? Little s is present on screening cell 1 and 2. And that's it.
Could be JKB.
Yes, could be JKB. And again, it could be combinations. So it could be a combination of big C, big E. It could be a combination. Let's see if there's any other possible combinations. I'm watching my Duffy because they're notorious. Sometimes you'll have like an RH and a Duffy, but screen filter is negative. So. Okay, with that being said, this is just a screen, all right? And again, so our next step would be to run a panel for definitive antibody identification, right? So you'll have to run a series of either 11 or 16 more cells, depending on which manufacturer you go with. There's also, remember we talked about dosage? Do you guys remember talking about dosage when a cell is heterozygous, right? Especially for big C and little c are considered a pair. So you have to look for heterozygous expression among them. Big E and little e, heterozygous expression. Big K, little k, Carol and Chelano. Duffy A, Duffy B, JKA, JKB, Lewis A, Lewis B, big S, little s, they're inherited as a haplotype, right? So you have to think about, are they both being expressed on the cell, or is only one antigen site being expressed on the cell? So take an example, screening cell number 1 is heterozygous, big S and little s. That means that that cell is sharing antigenic expression, big S and little s. So actually, if it's heterozygous, the antigen sites are weaker, all right? So typically, we could see dosage in our patient plasma. We might see a weaker reaction with screening cell 1 than we would see with screening cell 3, okay? Because we could have the antigenic expression is weaker here than the homozygous cell here. So all of these antigen sites on this screening cell 3 are big M. Doesn't have any N sites, okay? So there's more M expression, meaning that the reaction could be stronger. And so you always have to look at the reaction of your strength as well. That will let you know if dosage is being demonstrated or if multiple antibodies are present, okay? So if you had a 3+ reaction on screening cell 1 and a 2+ reaction on screening cell 2, number 1, is it dosage causing that discrepancy in reaction, or is it multiple antibodies reacting, okay? For this patient, do you guys think it's an allo antibody or an auto antibody? Allo, because your auto control is negative, okay? So here's all your possible antibodies. Notice that D is on screening cell 1 and 2, JKB is on screening cell 1 and 2, and little s is on screening cell 1 and 2. But we cannot rule out the fact that it could be a combination of big C and big E. That might also be an option. Like I mentioned, always pay attention to your expiration date, the reagents. The cells do lose their antigenic expression over time. Also, pay very close attention to lot numbers. You're going to have your screening cells that you use. You always want to make sure that your antigenic profile matches the lot number that you're using. The reason for that is if you grab the wrong lot number, antigenic expression from like maybe a previous lot number, then the antigenic expression on the cells might be different. You could potentially identify the wrong antibody. Okay, so we always want to pay attention to the lot numbers. All right. And we want to use fresh serum or plasma. You're going to mix your patient plasma with screening cells 1 and 2. Going to perform an auto control, and your auto control again, patient cells and patient plasma. If you have a positive auto control, that does indicate an auto antibody, right? And then again, you'll have initial spin, room temp, 37, and AHG. I want you guys to understand initial spin and room temperature. They're used interchangeable. Okay? They're the same thing. Initial spin or room temp test. Okay? They're the same thing. That means you add immediate centrifusion rate for agglutination. That's your room temp test or your initial spin test. And then after each phase, you will read for agglutination. Okay? If you have a positive reaction, that means antigen antibody has combined. Okay, you do have an antibody present. If you have a reaction at initial spin, again, remember IgM antibodies can react at initial spin. You may also observe hemolysis. One thing about hemolysis is you're probably going to notice your cell button is very small as well, and that's just because the cells have lysed. 37 incubation, again, check for agglutination, check for hemolysis. And then how long you incubate is dependent on what enhancement media you were using or if you used any. And then your AHG. After your 37 incubation, you'll read for agglutination, and then you're going to wash. Remember, before you add AHG, we always want to wash our cells to remove any unbound protein, okay? And usually wash 4 times. And then if it's negative, macroscopically, you will have to check it under the microscope. And then if it's still negative under the microscope, always, always, always remember to add check cells to your AHG tubes. Your tube will then go positive, okay? But that does not reflect your patient result. That is an internal quality control. If you have a negative tube after addition of check cells, your test is invalid. That means something wasn't performed properly. Whether you didn't wash appropriate, you have excess protein in there, maybe you totally forgot to add AHG, okay, that's why we add the check cells. It confirms the validity of the test. You guys have something at 11? You have molecular? Okay. There's some false positives and false negatives. Dirty glassware. So if you have anything in that tube that might be mistaken for agglutination, that could cause a false positive. If you over-centrifuge, meaning that the cells are packed together very strongly, that could cause a false positive. Overreading could cause a false positive. Cold auto-antibody that is present will cause positive as well. False negative, very important. Improper washing can cause a false negative. Okay, and that's just because if there's any excess protein, it could neutralize your AHG reagent. If you forget to add your plasma in the IAT, there's no antibody, okay, so it could cause a false negative. If you forget to add your AHG, all right, that could cause a false negative. If you have prozone or postone, both of those will cause false negatives. If you under-centrifuge, if your shaking technique is too hard, okay, so that's why it's very important as you guys shake, monitor that cell button. As soon as it loosens from the side of the tube, read for agglutination. Is it truly negative? If you overshake, the more you shake, the more that cell button's gonna break up, the weaker it's gonna get, all right? So if you shake too hard, you could get some false negatives. And then make sure you're able to identify any weak positive reactions. Don't forget to check your AHGs under the microscope, all right? You have to be able to identify those microscopically positives. And that's it. So we talked about the DAT versus the IAT. You guys will get to do both of these in lab. Just make sure you understand DAT is in vivo, right? The IAT is in vitro. Both are detecting antigen-antibody complex, but in the DAT, we're looking for what has already coded patient red cells inside the body. In the IAT, we are forcing that antigen-antibody complex to occur. We want to identify any underlying allo antibodies, okay? All right. Anybody have any questions?